Next slide, please. So just a summary on what we see this week in the data as well as in the modeling. The Omicron wave has reached almost everywhere with a few exceptions, still not taking off in many Southeast Asian countries. The Philippines has a very large surge, but it has not yet hit Indonesia, Malaysia, Vietnam, Cambodia. We have seen a handful of places, Slovakia, for example, in Europe, where it still hasn't taken off. But it is either underway everywhere else, or in the case of zero COVID countries, China, New Zealand, there are community cases, but the exponential surge has not yet started. Where we have seen, we've quantified the timing from the abrupt upturn in reported cases to peak. And that appears to be, regardless of place, in the range of 20 to 25 days. There's a few exceptions to that, where the peaks have occurred even more quickly. But in general, we're seeing that there's a 3 to 3.5 week period from exponential increase to flattening out, and then cases starting to come down. In our models, we still see that 50 to 60% of the world is likely to be infected with the Omicron wave once it's complete. Now, the wave does lead to a surge in hospitalizations with such a massive increase in infections that compared to all previous variants. Even though the fraction of infections that end up in hospital is much, much lower, we still see a surge. That surge in officially reported data, depending on the country and their rules around testing all patients being admitted to hospital, does include a considerable number of people showing up to hospital with other conditions that happen to incidentally test positive for COVID. Now, this could have been happening in the past, but we've never had such high levels of community infection before. So incidental admissions in previous variants weren't really much of a consideration. Now, with so much Omicron transmission, we're seeing many places with up to 50% of hospitalizations are in patients that are presenting with something other than COVID. Nevertheless, the pressure on hospitals is real. That's both because of the surge in people presenting with COVID, the surge in those that require infection control because they're COVID positive, and the shortage of healthcare workers because they're testing positive and having to quarantine at home. The good news is that now 7 weeks into the Omicron wave, it's very consistently clear that the infection fatality rate is dramatically lower. Next slide. So here's this week's models. The main thing that we've done here is we have gone from modeling the handful of provinces in China that had transmission in the past, which was a very small number, to modeling the whole of China and including an Omicron wave in China. We do not think that China will be able to contain Omicron. And so that little kink in infections on the left is the wave spreading through China in our models this week. And we still expect that the global peak of infections is 10 times the previous peaks that we saw for the Delta wave back in April when it was in full course in India. And the US peak is quite similar to what we have previously been modeling. And in fact, we believe that the peak of infections has already occurred in the US. And so the peak of cases should be coming soon. Next slide. Now, sorry, go back to one, please. You want to head to? So on hospitalization, on the census count, These numbers do include the incidental hospitalizations, but you can see, for example, that we are expecting more hospitalizations, which we're observing, than in the winter surge last year. Bearing in mind that, you know, maybe as much as half of those are not actually present for COVID. And at the global level, not quite as high as the previous surge for Delta that is shown here on the left side. So in intense hospitalization pressure, absolutely. Next slide. The rise in deaths is very small. And in fact, depending on the country or the place, if a country or a state had an ongoing Delta wave, it does appear that the death rate may actually fall as the Omicron wave comes in and replaces Delta. And so we've seen that in a number of jurisdictions. And at the global level, we're not expecting much increase overall in the death rate, given that Delta replacement phenomenon. In the US, we are seeing an uptick. Again, these deaths do include the incidental deaths. So not only do we have incidental hospitalizations, but of course, if those people, according to most states' approach to COVID death reporting, if you get admitted, test positive, even if you're there for a heart attack and you die, you are going to show up in one of the categories for COVID death. Next slide, and the last. So how do we put this all together? Well, massive wave of Omicron, it happens very quickly. It goes up and then comes down wherever we observe it. We're seeing brisk declines in places like Malta or the UK, Maryland. We're actually seeing quite substantial declines in countries in, even though there's huge underreporting, but most of Eastern and Southern Sub-Saharan Africa, this wave is now complete and very much on the downswing. But what do we end up with at the end of this? Because it's so much more transmissible, there's so much immune escape, we end up with the highest levels of global immunity that we've seen in the pandemic, both from the Omicron wave, but also from ongoing vaccination. So we expect after the Omicron wave, a period of low transmission of COVID. And we also think that as we're seeing in Europe and a number of other countries starting to follow suit, that given the much lower severity for Omicron, given the extraordinary transmissibility, the ineffectual nature of contact tracing and quarantine, that most countries will drop restrictions as the wave subsides. Now, we strongly believe there will be new variants. But do not expect that even if new variants are more severe than Omicron, which is certainly a real possibility, that we will return to a set of extraordinary mandates or restrictions, because the people at greatest risk, who are the unvaccinated and never infected, are increasingly a small fraction of the world's population. We have ongoing efforts at vaccination. We have the advent of highly effective antivirals that, as production capacity increases, it should really make a dramatic difference to the case fatality rate. And of course, people now know that they can protect themselves through behavioral change, wearing a high quality mask, and social distancing for those individuals who are at high risk. So that leads us to conclude that the era of major restrictions is coming to an end, and that COVID will be around for the long term, but it'll be a disease that, like a bad flu, we will need to manage through the health system on an ongoing basis.
Thank you, Dr. Murray. The first question is from the Associated Press. A scientist on Twitter reacted to the Lancet commentary, sharing photos of Dr. Deb Birx with the 2020 projections, trying to make a point about the uncertainty of projections. How much uncertainty is in these latest projections, and what would you say the range is when you get beyond April?
Well, you can go online and see our uncertainty intervals. They're very large, of course, because there's lots of factors that go into modeling that we don't know. After April, where our numbers start to get very low around the world, the question is the timing of a new variant. When will the next new variant show up? Because if there isn't a new variant, then we would not expect cases to start going up again till later in the year due to two factors: waning immunity, both infection acquired and vaccine derived, and seasonality. So our models, when we don't release them publicly, but our long range models show a winter surge next winter in the Northern Hemisphere. But of course, that can be entirely overcome by the emergence of a new variant, which currently we don't model the probability of a new variant emerging. It's extremely hard to sort of quantify in a quantified way or a quantitative way to sort of guess at when new variants emerge.
Thank you, Dr. Murray. And then a second question, you're not using the term herd immunity. Why is that?
Herd immunity is an idea that says, or used to be, that came from mathematical modeling that said you would reach a certain level of immunity, and that will mean R effective drops below 1. But what we've learned through the course of the pandemic is that there are many factors that drive transmissibility. Human behavior, how much, when people were really worried and social distancing and wearing a mask, that can lead to transmission peaking and coming down, even though it's nothing to do with levels of immunity in individuals. We know that that COVID is highly seasonal, so that the level of herd immunity required in the winter to bring down transmission is higher than in the summer. So it is a challenging idea because it moves depending on where you are and when you are. However, the reason we see this abrupt peak and decline in the Omicron wave is that we think we are running out of people to infect very quickly. It's so transmissible, it's ripping through the population. Many of the infections are asymptomatic that we think we get to functional herd immunity for this wave. Now, because immunity wanes, we will have people back available to be infected as time goes by. So you don't get to this level and then it's all done forever, because the immunity levels will wane over time.
Thank you, Dr. Murray. With that immunity waning over time, you mentioned a winter surge. Is there a possibility of another Omicron surge?
Well, the one in the long range models would be an Omicron surge, because until something that is more transmissible than Omicron, we don't see other variants reemerging. There has been a debate about whether Delta could reemerge, but so far studies suggest that Omicron provides reasonable protection against Delta. So we're hopeful there won't be a return of Delta, in which case the surge next winter would be Omicron until a new variant comes along, which is very likely, and replaces it.
Thank you. The next question, as Omicron subsides and restrictions are dropped, will we see a relative return to normalcy, and could the virus become endemic?
That's what we believe is happening. We think that because this wave will move quickly through the population, we will go into this period where the immunological exposure to COVID is so much higher, both from vaccination and infection, that we won't see restrictions return. So I think we will go back to normal in the sense that we won't have major restrictions on behavior, and that COVID becomes endemic. It's just a disease that we will have to manage.
Thank you. There doesn't seem to be much of a difference in the case projections with or without masking and booster doses in the latest forecast. Are these measures unnecessary? And should countries be lifting restrictions like mask mandates and vaccine passports?
Yes, in all previous cases, we've seen a very marked population level effect of increasing mask use. And the reason we don't with Omicron is that it's so transmissible that even if you protect yourself and decrease your risk by 50%, which is what a mask probably does, you're still going to get exposed multiple times to Omicron. It's that prevalent in the community. And that's why at the population level, unless you put these interventions in before the wave starts, and put the brakes on transmission before the wave starts, by the time you scale up mask use in the models, it's sort of too late. So in China, we see a benefit of increasing mask use because the wave hasn't started yet. Same in New Zealand, and in countries of Southeast Asia. But once you've got your wave in full force, it's so fast that policy interventions don't really do much. Now, should you drop restrictions in the middle of an Omicron wave? Probably not, just to be cautious, because the wave will be over soon. You just need to wait 3-4 weeks, and the Omicron wave will be done. And in a setting of uncertainty, it's probably wisest to keep going with your current set of strategies until the wave subsides.
Thank you, Dr. Murray. And then a follow-up question to clarify, are we saying the pandemic will be over by May?
So it depends what you mean by pandemic. What I mean by pandemic is not that there's a disease out there like seasonal flu, but the notion of pandemic has come to mean this sort of emergency response that we've all been living for 2 years, that requires extraordinary government and societal action to protect us all from the COVID-19. So in that sense of the pandemic, I believe is over by April. But COVID will still be with us. So in the sense that we don't describe seasonal flu as a pandemic, in the same way as we move to an endemic state for COVID, I believe the emergency nature of the pandemic is over.
Thank you, Dr. Murray. The next question, should countries with low vaccination rates or limited access to antivirals treat the pandemic differently? And can COVID be truly endemic with much of the world still unvaccinated?
Well, what we have learned is that as time goes by, more and more studies, that the group that is at greatest risk are the unvaccinated and never infected. So the people who you might describe as immunologically naive, they've never seen COVID either through some aspect of the vaccine, like the spike protein, or through natural infection. We're at the point at the end of the Omicron wave where there are few people left in the world that are going to be truly immunologically naive, which is why we're in a better place. Because if you are fortunate to get through natural infection without a bad outcome, you do end up with considerable immunity, potentially immunity that is as good as or potentially better than vaccines, and wanes perhaps at the same rate or more slowly. So that puts the world in a much better place. And those that had low vaccine access will actually end up with quite reasonable levels of immunity. Look at what's happening in India, for example. Although there's been a concerted effort to vaccinate, the enormous Delta wave appears to mean that India's already peaked in many states for Omicron at levels lower than perhaps we had expected 3 weeks ago. And that's likely due to the levels of protection that the Delta wave gave them. However, on a pure equity basis, we strongly think that everybody should have an access to a vaccine, and hope that vaccine scale up will continue.
Thank you, Dr. Murray. The next question is about recording infections. Should people who have been vaccinated, boosted, and infected make a note of that in some way? For example, on our vaccination card, should we list infections in some manner?
It's very interesting. If you go back to May of last year, if you remember, US CDC said we shouldn't even test the vaccinated. of course, because at that time, I think there was the belief in some circles that vaccination was going to do a great job at preventing infection, even for Delta. Now, we've learned subsequently that vaccination is great at protecting against severe outcomes, hospitalization and death, not very good at for preventing infection, certainly for Omicron, not very good at all, maybe 35% protection. So there are these people that have been, triple vaccinated, and some people have even had 2 bouts of COVID, and that probably just with good outcomes because they've been vaccinated, but that probably just enhances their immunity. So I think it's something that, in terms of your personal health record, it's something you would want your healthcare provider to know that you've had tested positive once, twice, or however many times, because it would help understand what your likely level of immunity is.
Thank you. And a similar related question, if interventions at the policy level are no longer needed, what kind of changes should people make from an individual standpoint?
From an individual standpoint, personally, I'm going to be cautious until the wave is through, which is just a few weeks away. So why in a world of always uncertainty, why take any risk? Once the wave is through, I think that everybody will have to make their own choice, and it sort of goes back to take a bad flu season, 2017, 2018, the winter, which was a bad US flu season. What type of differences in behavior did you pursue when there was a bad flu around? And some people who are at risk or older already back then would have taken, avoided people that were sick. We now know that mask use is quite effective for individuals, even if it's not going to be very effective at the population level because it's Omicron so transmissible. So I think individuals will want to make their own choice about their, willingness to take risk. I sort of believe that as we face future waves of COVID, given we know it's the older population and those with comorbidities that are at greatest risk, and that has stayed true throughout the pandemic, some individuals may choose to seasonally or during a wave wear a mask. I think the distinction is that we won't see, requirements to do that.
Thank you. The next question is, what kind of testing and quarantine strategy do you recommend today?
Testing and quarantine does not appear to be practical or having an impact when you have so much infection in the community. If at a given day, 10% of people, which is realistic numbers, are PCR positive, if you went out and sampled them at the peak of transmission, that means, typical household of 3-4 people, that would be half the population if you found all these people that would have to quarantine on any given period. You just can't do it. We don't have the capacity to find all these infections, get them to quarantine, nor would it do much given the fact that it's so transmissible. So the whole strategy of detecting infections and quarantine probably is not having much of an impact at all on Omicron. Worked hugely usefully for previous waves. But once you have something this transmissible, probably quite futile.
Thank you. I don't have further questions, so I'm going to wait just a moment. I did want to clarify one thing about the previous question about mask use in the scenarios, just to be very careful for everyone on the call. The mask use scenario is bringing mask use up to 80%. The reference scenario is current mask use, so that is not zero mask use, the difference between those two. All right. I don't see any more questions, so I think we can give you all some time back. Thanks very much for coming.
Thank you.